Hello, I'm Antoniades from the University of Oxford, and it's my great pleasure to be with you today, even remotely. I want to talk to you about artificial intelligence in cardiovascular medicine, and I want you to start thinking about whether we are ready to accept what it brings us. These are my disclosures, my conflict of interest disclosures, and the most important of which is that I'm an intense user of AI in both my research and in my clinical work. Now, the highly intelligent skills like visual perception, image recognition, speech recognition, decision-making, prioritization have all been considered until recently as a privilege of the human brain. However, this is no longer the case. AI can perform all of these tasks, and in many cases, it can perform these tasks even more effectively than humans ourselves. Every time we talk to our chatbot, to our Alexa, or try to talk to our Siri on our iPhone and so on, an AI algorithm kicks in, makes assumptions, makes conversations, gives answers to our questions. Every time we try to unlock our phone, there is an AI algorithm recognizing our face and unlocking the device for us. I went to San Francisco a few months ago, and I got into a taxi to only realize that actually there was nobody in the driver's seat. It was a driverless car that took me to the other side of the city. It was not making conversations, but it was a very, very good driver. Now, what has changed with these chatbots over the last few years? Since the introduction of ChatGPT, DeepSeek, Copilot, the big change is that these tools are now in the hands of everybody. You don't have to be an engineer. You don't have to be a specialist. You don't have to know exactly what AI is about. You can now use it in your hands. And now we have various key stakeholders that have different expectations from these AI models or large language models. And which are these stakeholders in medicine? First of all, you have the patient. The patients, they want AI to have a direct first line of contact with the healthcare systems. They want to use the AIs for education, to get advice for lifestyle and so on. The physicians, we want to use AI for fast literature review, fast case review, to help us go through differential diagnosis and repetitive tasks, boost the overall performance as clinicians in our clinical practice. And then we have the healthcare systems, the managers, the hospitals. They want to cut down costs. They want to monitor patient flow. Many tasks performed in the hospitals now are automated, administrative tasks, performance monitoring. There are even consultation rooms that are run now by AI. And of course, the researchers, we love AI because it helps us go through large multi-dimensional data sets very fast, very effectively. Tasks, repetitive tasks like segmentation of images, for example, are now done by AI, and then we cut down the costs of running our groups. However, all this brings a number of questions. First of all, the patients, they start to wonder, do I really need a doctor if I can get my answers from an AI? Then the healthcare systems wonder, do I need admin or medical staff? The researchers, they say, do I need fellows, technicians? Because most of the tasks now can be done in an automated way. And of course, the clinicians start thinking, do I even need to think? Because if AI does the thinking for us, then we very likely will get de-skilled at some point. I was in a ward round a few weeks ago, and we are discussing this very complex case. You don't need to go through the case line by line. After half an hour of discussion, the most junior member of my team stepped forward and said, I believe this is AL amyloidosis. We all looked at him, and we thought that, it was particularly weird that an inexperienced F2 junior doctor would give a diagnosis so easily. And then he showed us this. He entered the details in ChatGPT, and then it gave him all the details as to how are we going to process this information, what's the differential diagnosis, what tests we need to perform, and it gave a likely diagnosis of AL amyloidosis without even having the tests available. And indeed, we have done all of these tests, and it was AL amyloidosis. This tells us how close we are in essentially not only using AI to aid diagnosis, but even to replace us in making the diagnosis. From this diagnosis, we can go to prevention, from prognosis to prevention. We now use all these prognostic models in primary prevention, like QRisk3 we have in the UK, which get a decent performance in predicting cardiovascular risk. But now with the AI models, all of them outperform this classic conventional prognostic models. And they use the very same risk factors as the ones we use in conventional models like QRisk3. In secondary prevention, we have the GRAY score. Now we have the GRAY 2 score that is coming out in the Lancet in a couple of weeks. You have seen in all these papers that you get this unbelievable performance in predicting events, and in this case, in predicting mortality in hospital after a non-ST elevated myocardial infarction. Now, we can use AI to interpret more complex data sets like ECG, to interpret ECGs. And from this study, from the Mayo Clinic, published a few years ago, you can show to these AI models ECGs of patients on sinus rhythm that can tell you pretty accurately whether this patient has episodes of paroxysmal atrial fibrillation. Similarly, from the same group, there was another work published more or less at the same time, showing that you can get very, very accurate detection of LV dysfunction from simple 12-lead ECGs. And more recently, there has been another study showing that you can even predict future heart failure. This is coming from the Yale group by looking into ECGs. Now, what is common between all these studies is this last line. To train these models, you need hundreds and hundreds of thousands of ECGs. And when you have access to these hundreds of thousands of data sets, then you can perform a very accurate model building and you can build very accurate prediction models. Now, a few years ago, when I was still a medical student, I was really impressed by our senior clinicians in the department. I had a very senior academic who was coming into the ward and was looking at the patient from the other side of the room and was giving us a diagnosis. And more than half of the cases, he was right. Now, how could he get this end of the bed impression so accurately? Now, it seems that there is a logical basis behind this. There is this study published a few years ago from a Chinese group showing that even by simple face recognition, you can identify characteristics by using AI of the face that give you a very good prediction or very good sensitivity and specificity in detecting subclinical coronary artery disease. And this is without even asking about whether the patient has chest pain or having any medical history. Then we have the applications of AI in imaging, in medical imaging, which is the ultimate complex data set that AI could ever hope to manage. Now, it is used extensively in imaging today to interpret multidimensional clinical patient and imaging data, put them all together, to improve the workflow in image processing, to improve the accuracy in image interpretation, like applying radiomics, for example, to see what we normally cannot see with the human eye, to help us prioritize tasks, for example, a fast exclusion of normal scans or normal X-rays allow you to focus on the abnormal ones. Fast quantification, for example, automated calcium score, coronary plaque analysis, and now we're talking about diagnosis and future risk prediction. And this is the main focus of my research group in Oxford. And I will talk to you a little bit more about this in a while. Now, how do we use AI to automate image segmentation? Every time we open an echo machine and we perform an echocardiogram, we always get this automated segmentation of the endocardium and calculation of the ejection fraction of the patients of the study. This is done by using an AI model. In my group in Oxford, we have trained recently another model that uses coronary CT angiography to automatically segment and quantify epicardial adipose tissue. And by doing that, we were then able to analyze tens and now hundreds of thousands of coronary CT angiograms very fast and get very valuable information about the role of epicardial adipose tissue in predicting cardiovascular risk. More recently, we have received the news from the US that there is a Category 1 code for reimbursement of AI-assisted quantification of plaque on coronary CT angiography. So now all these models that quantify plaque and the different types of plaque from coronary CT angiography are reimbursed with an extra dedicated code in the US, and this is a big step forward. Now, in cardiovascular medicine, we have been focusing for many, many years in understanding how heart attacks happen. We thought for many years that heart attacks happen when these large plaques break, giving this thrombus and occluding the coronary arteries. It has also been clear over the last few years that many heart attacks happen when these intermediate lesions, these small, sometimes not even visible with the naked eye, plaques rupture. And the question is, how do we find these plaques that are going to rupture? And the key pathophysiological mechanism behind plaque rupture and acute coronary syndromes is inflammation. Inflammation is what triggers the development of atherosclerosis, and it's also what triggers the rupture of atherosclerotic plaques. In a recent study that we published a few months ago in The Lancet, we have seen that in the 40,000 patients undergoing coronary CT angiography, only 18% had obstructive coronary artery disease. However, 2/3 of the heart attacks happen among those without obstructive coronary artery disease, which means that we need to develop ways to be able to measure inflammation in the coronary arteries in order to capture these patients who are at risk for heart attacks, even if they don't have visible plaque in their coronary arteries. In my group, we have been focusing for many years in understanding how the vascular wall communicates with the surrounding environment, and particularly with the perivascular fat. And we have found that when you have an inflamed artery, like the one in the middle, that secretes inflammatory molecules to perivascular space, and the adipocytes, you see here in the perivascular fat, they become small and fat-free. Depending on the type of inflammation, you get very complex changes in the texture and composition of perivascular adipose tissue. And these changes happen before you have the development of atherosclerotic plaque in the vascular wall. If we were able to see these changes somehow, non-invasively, in the perivascular space, we'll be able to identify the coronary artery that is inflamed. In coronary CT angiography, we get these black and white images. The fat surrounding the arteries is not visible, it's suppressed. This is black area around the arteries. We have developed a method that's called fat attenuation indexing that brings this information to the surface. And by performing a certain quantification of the gradients of the attenuation of the signal in coronary CT angiography around these arteries, we can tell that this artery here in the middle is inflamed. And you can see this red color accumulating, or even the blue color, which is severe lipolysis in the perivascular space. And you can see that as time goes by and inflammation gets worse, you have these striking changes in the texture and composition of the perivascular fat. This information is not interpretable in the human eye without applying some kind of sophisticated analysis of the perivascular space on CT angiograms. The fat attenuation index that was originally developed to capture these changes in the perivascular space was then tested and validated in the Acute Multidisciplinary Imaging Interventional Center. This is our dedicated research cath lab that has a table that is detached and slides into the photon counting CT scanner that sits in the same room, allowing us to perform this kind of studies, identify using intravascular imaging lesions that are highly inflamed, for example, in the context of an acute myocardial infarction, and then perform the coronary CT angiogram at the same time as the invasive angiogram and capture this red color around this highly inflamed plaque, confirming that we can pick up at a localized level the highly inflamed atherosclerotic plaques by using this method with a sensitivity and specificity that exceeds 90%. Now, since we developed this technology originally, the regulators, to turn it into a clinical application, had a very high bar. So we had to work to transform the original pericoronary adipose tissue attenuation metrics, this PCAT metrics, into the fat attenuation index, which was corrected for technical factors, and eventually the fat attenuation index score, which takes into account anatomical, biological, and further scanner corrections, and implements an AI model to give you the exact metric of inflammation for each one of the 3 coronary arteries in a standardized way. This was described in a recent clinical consensus statement from the European Society of Cardiology, which was dedicated on this matter. In terms of the basic science behind it, you can see that in postmortem CT, when you have abnormal fracturation index, so highly inflamed coronary arteries, this means that there is a lot of accumulation of CD68 positive cells, these macrophages, inside the coronary artery. And when you transfer this information into the population, then you can see that having highly inflamed coronary arteries gives you between 5.6 and 9 times higher risk for a fatal cardiac event, even after you correct for age, sex, risk factors, calcium score, or the presence of high-risk plaque. Of course, in order to build AI models to predict risk from these images, you need to scale it up, and you need to make sure that anything you generate is reproducible around the globe. This is why we launched the orphan study that currently it has enrolled so far 210,000 patients with coronary CT angiograms followed up prospectively for the rest of their life, and 175,000 of these patients come from the UK. The first pilot results from this study were published in The Lancet a few months ago, showing that if you belong on the top 75% of the top 25% of the distribution of inflammation using the PHI score, you have 10 times higher risk to die from a cardiac event if you have not obstructive disease, if you don't have obstructive disease, and 5 times higher risk to die if you do have obstructive coronary artery disease compared to those on the bottom centile of the distribution. Of course, looking at the big picture, you will realize that we have so much information that the human brain cannot interpret. Only from the coronary CT angiography, we can get information about plaque, about the composition of the plaque, about the hemodynamic significance of plaques, about inflammation now, and looking into the actual anatomical results from the coronary CT angiography, you realize that we have 20% of actionable plaques, 40% of minor, not actionable plaques, and 40% of the patients without any plaque at all. Now, how do we take all of this into account in order to change management of our patients? And this is exactly where AI comes to integrate plaque, risk profile, risk factors, inflammation, clinical characteristics of the patients together into prognostic models that can predict accurately the risk of the individual for a cardiac event. And this is the AI risk model that we have developed a while ago, showing that when you feed a coronary CT angiogram into this model, it extracts information about plaque, about inflammation. It takes the risk factors of the patient into account and generates the absolute and relative risk of the patient for a fatal cardiac event over the next decade. The model was originally trained in the US, then it was validated in Germany, and recently it was transferred to the UK as a locked medical device for external evaluation. And the area under the curve in predicting cardiac mortality was 0.84. And for those who can read these calibration curves from prognostic models, you realize that the ideal dotted curve essentially overlaps with the predicted risk curve presented in this diagram. Now, in the orphan study, we asked the AI to give us prediction of events that happen in the 3 levels of risk that are actionable based on the guidelines. And we have, based on the guidelines, we have the very high risk individuals that they need additional treatments like ezetimibe, anti-PCSK9, colchicine, and so on. We have those who are the intermediate risk that need statin or increase the dose of statin. And then we have those who are at low risk who only need lifestyle and diet interventions. We asked the AI to plot these curves based on the scans, but these were not real events. Then we opened the labels, and these are the results. Essentially, the solid lines represent the 2 observed events. The dotted lines represent the predicted events. And you can see that this is nearly an absolute overlap between the predicted and the true observed events in this population. When we find these highly inflamed patients, what do we do? If we start studying treatment, we can see that this reduces the risk for a fatal cardiac event, the AI risk, the calculated risk, by 30 to 40%. And it's exactly what we have observed from the randomized clinical outcomes trials with statins over the years. In a recent study, in recent randomized clinical trial with ortikimab, which is an antioxidase LDL monoclonal antibody, 12 weeks of treatment resulted in 40% reduction of the calculated 10-year risk of these individuals after they were treated with ortikimab. While if you look into women with breast cancer having radiotherapy, you can see within 2 years after they have treated their original tumor, a 20% reduction of the risk for a fatal cardiac event over the next decade. And this from our recent paper that had just come out in the European Heart Journal. In the UK's NHS, this technology is being used clinically, and we record how it changes the management of patients. Essentially, the clinicians record the management that they would put together normally without having the information about inflammation or risk stratification from this AI model. And then they are presented with the report and they change the management of the patients. Then they record these changes. And the results are what you can see here on this figure. By knowing this information, by taking into account the AI advice and the guidance in managing the patients, this leads to 45% changes in management of the patients. This splits down to 24% of the patients starting treatment, 13% increasing the dose of statin, and 8% starting additional treatments like colchicine, ezetimibe, EPAs, etc. A health economic model that was put together very recently in the UK by the National Institute of Clinical Excellence, NICE, has revealed that at the price point of £300 per analysis, you get a very, very cost-effective, incremental cost-effectiveness ratio, which comes down to £1,300. So these AI models are extremely effective, very accurate in predicting the risk, but they are also at a very low cost compared to clinicians. Now, how can we affect the actual outcomes? From a recent study we published a few months ago, we have seen that if you implement this technology in the NHS today, you expect 11% reduction of myocardial infarction, 4% reduction of heart failures, 4% reduction of ischemic stroke, and also 12% reduction of cardiac death over the lifetime of the individuals. Now, are we ready, or is AI essentially taking over? There is a lot of many discussions are taking place about how AI, for example, can be used for fraud, to clone voices. People even talk about an AI apocalypse with the Terminator, and they wonder whether the robots are coming to conquer the earth. But are these risks real? And what challenges do we have ahead of us, especially in healthcare? First of all, we have the data privacy and security concerns. What happens if there is a data breach? How to manage patient consent? On the data quality and availability, we need standardization. This is not always possible. The results need to be accurate, and how do we test reliability? And particularly, how do we address the black box issue? How to understand how these models work? There are many ethical and legal concerns about who is responsible if something goes wrong. There are a number of regulatory and compliance challenges. So the legal framework is not mature to support this kind of technologies. Integration into the existing systems, into the electronic healthcare record, this is a lot of technical work that needs to take place. The cost implementation challenges, sometimes implementing these models is particularly cost, so it's cheap to run them. And then we have ethical use of AI in clinical decision making. And of course, there might be a model drift. How can we monitor, maintain, and prevent bias in these AI models? And of course, it's the socioeconomic impact. If everybody loses their jobs because of AI, then who is going to spend money to keep the jobs going? All these need policies. And the question is, who develops the policies? Who checks if they're implemented? Who enforces these policies? And how to engage with regulators and policy makers in a globalized world that we live in today. So de-skilling of healthcare professionals is probably the biggest the problem that I see at the moment, because as clinicians, yes, we can use AI, but we need to be able to continue to be doctors if there is a power cut and we don't have access to these AI models. So AI gives enormous opportunities, but only if we mitigate the risks. And I believe that the good doctor of the future will be the one who knows how to use this AI without, however, becoming dependent on it. And that's the conclusion. That's the key message that I would like to give from this presentation. Thank you for your attention.